Right, welcome everybody. I think we can probably get started now. Great, so thanks so much everybody. Good afternoon and welcome to our webinar to introduce the Horizon 2020 funded project CBIG-SCREEN. We're absolutely delighted that you're here. Just some housekeeping before we start. Apart from the speakers, all cameras and mics have been muted. If you have any questions at any stage, please feel free to use the Q&A function. We'll be keeping an eye on them, and we hope that we'll have time at the end of the session to get to some of the questions. So please feel free to pop in any questions there as and when you think of them, and hopefully we'll get to them at the end. So this meeting will be recorded as well, just to inform you. So I think we could probably get started now. We're 3 minutes past, so we might as well. So let me start by handing over to Mrs. Sirpa Pietikainen, EP. She's our co-host for the meeting. So thank you so much, Sirpa, for being here and for hosting this with us. We're delighted to have you here. So I'll hand over to you now. Thank you.
Thank you. And once again, I'm so happy on hosting this event together with European Institute of Women's Health. And please do your Google and check the activities of the Women's Institute of the European Institute for Women's Health in other areas concerning gender issues, women and health. They do excellent work, so very happy to work with you also in this issue. And so on behalf of them and myself, wholeheartedly welcome, and I'm very happy to see you and start this bigger discussion about how cervical cancers could be better screened, better treated, prevented, and being phased out as this kind of a major cause of major cause and major threat for death among European women. And just to let you know, I'm also the member of MEPs Against the Cancer MAC interest group. That is one of the oldest, and that is the biggest cancer group, and we have been actively pushing forward to have this European cancer plan. That's what we indeed have at the moment. And we are still continuing our work together with the Commission in order to improve cancer control, diagnosis, prevention, research, then of course high quality treatment, breaking down the inequalities of treatment, and then helping people to adjust back to the working life and everyday life after the cancers. And of course, this concerns also people with cervical cancers. And as you know, cervical cancer is female typical disease and a cancer. It is the third most common gynecological cancer, and the second most common in women under 48 of years. So very relatively young women. Then the another targeted point there is the women after they pass the age 60. And in Europe, over 61,000 women are diagnosed with cervical cancer each year, with almost 26,000 deaths, where I'm pretty assured that if we would have a good concentrated program on cervical cancer, we could erase the vast majority of these deaths. This relatively high death rate has been largely attributed to low vaccination coverage, low cervical cancer screening, and especially the rates are very low among vulnerable women, and still sometimes even the same, and accessibility to gynecological services are preventing the early access on diagnosis and treatment. What is very remarkable is that there's a substantial variation across the member state in terms of both incidence of the disease itself and the mortality rates. Eastern and Central European countries have the highest incidence rate, while most Western European countries fall below the EU27 average. And then again, it is the same when you look at the screening. The lowest figures are in Central Eastern countries, where just barely above 20% of screening, up to almost 90% in some of the Western countries. And this explains partly, but not only the whole incidence of death, but partly also this. And the similar variation, of course, is in terms of the mortality rates, where again we can see the harsh split between Eastern and Central used to be Central European countries and Western European countries. And most cases of this cervical cancer are preventable. And this is the good news and bad news. Bad news when it concerns where we are at the moment, since almost all of them are caused by human papilloma virus, the HPV. And there are around 100 different types of HPV viruses, beyond the 100. And roughly 40% of them can be sexually transmitted. So girls usually get it in fairly early, young stage of the age. And at least 13 types of this HPV are considered to be cancer causing. And to high risk types alone, the HPV 16 and 18 are responsible for about 70% of all cervical cancer worldwide. Vaccines that protect against these high-risk strains of HPV have been developed and used to great effect in national vaccination programs in some of the member states, including mine, where the young girls above the age of 10 are vaccinated by normal routine vaccination programs against the HPV. Vaccination programs and national cervical cancer screening programs represent the best available strategy to tackle incidences and mortality from this largely preventable disease. And that's why we should set our focus on this issue, and it is a gender issue also. The screening for the disease is recommended not only for women that are unvaccinated, but also for those who have been vaccinated, in order to target the 30% of cervical cancers that HPV vaccine does not offer protection. We all know that none of the vaccinations in the world are 100% proof, and that's why the vaccination doesn't set aside the need to improve the screening and put that as a basic right for the women, as well as it is for the breast cancers, as well it should be for in all of our member states to the breast cancers. And screening programs remain largely, even then when they exist, inaccessible and underused by different kind of subpopulations of women in Europe. For example, people that are marginalized, not very well educated, in the fringes of society, with the high long distances, disadvantaged, or other ways vulnerable, like immigrants, people with low social or socio-economic status, women living with HIV, women in prison, sex workers, women who inject drugs, and women experiencing homelessness, and so on. So we really see where to target the screening activities actively to get these people on board, as well as some subpopulation of some cultural areas or this kind of a national cultures that are skeptical against vaccinations and screening, and have taboos about the gynecological cancers. Well, this European Beating Cancer Plan is a key pillar of the European Health Union. It was launched last year, and it sets a new approach to cancer prevention, treatment, and care through a totally integrated health in all policies. So it is a basic constitutional right to all of the men and women, all the genders and ages and socioeconomic groups in Europe. And it has a multi-stakeholder approach too. We cannot do it only by EU, by member states, for patient organizations or science or medical community. We all need to work together to put this in practice. It has 10 flagships and multiple actions to tackle the entire disease pathway, starting from the prevention, screening, vaccinations, early diagnosis, high quality treatment, and then rehabilitation and helping people back to work and normal life. And earlier this month, the European Commission launched a series of initiatives as part of this cancer plan, where it focuses on the areas where EU can most add up on. And one cancer plan action is the Cancer Equality Register, which will identify the trends and disparities between member states and regions, and it will shed a better light than what we have nowadays on the structural inequalities in cancer prevention, screening, and structural inequalities due to gender, educational attainment, income level, as well disparities between urban and rural areas, and will guide investments and interventions at EU national and regional level. Another action plan as part of the Beating Cancer Plan is the Cancer Screening Call for Evidence, which will be used to update the 2003 Council recommendations of screening. And the target, and I find this very important, of this cancer plan, screening plan, is to ensure that 90% of the EU population who qualify for breast, cervical, and colorectal cancers are screened by the 2025, so only within a couple of years. And this focus on cervical cancer screening and marginalized groups is not only very important, but it's very timely. Only last week, the European Parliament adopted its final recommendations for comprehensive and coordinated EU strategy to fight cancer. This report on this BECA, that is the Parliament's Special Committee on Beating Cancer, is effective prevention measures at national and EU level based on independent scientific expertise, to upgrade the scientific expertise. And it also notes that more than 40% of all cancers are preventable through coordinated actions targeting behavior-related, biological, environmental, work-related, socio-economic, and commercial factors. Okay, Now I'll shut up myself and turn to the specialist to hear about this CBIG-SCREEN, which is a Horizon 2020 project that is in its first year on 5. And the aim of the project is to tackle these inequalities and inequity in cervical cancer screening through more efficiently targeting vulnerable women and thus accelerating cervical cancer elimination. And then when we turn up, firstly, the Professor Mark Baldoux of INSEM will be telling us more about, in detail, about the project and how we will achieve this. So once again, thank you for attending, and let's make the big cervical cancers a history in the EU. Please, the floor is yours.
Thank you so much, Sirpa, for that. Really interesting, just even highlighting all the inequalities that exist, but also geographically, which is very interesting. So with no further ado, I'll hand over to Mark to start speaking about CBIG-SCREEN. Professor Mark Baldoux is a professor at INSERM, and he's also the scientific coordinator of CBIG-SCREEN. Thank you, Mark.
Thanks very much. I'm going to share my screen. Okay, so now I hope you can see my screen. So thank you very much. And I think that many things have been already told about I would say, the European Beating Cancer Plan and who are the vulnerable women. So the CBIG-SCREEN project, which has been funded by the EU last year, is a project that is intended to work collaboratively with vulnerable women to find the best way to improve cervical cancer screening in the European countries. And I think that every word makes sense. And I think that the main idea of the project is really the fact that we want to work collaboratively with all stakeholders, and the first one are the women themselves. So the statement about the funding and the grant agreement number. Some key figures. So the CBIG-SCREEN project is a project with 14 partners across 10 European countries. We received 3.6 million euros funding from the European Union, and the project is going to last from 2021. So the meeting was launched roughly 1 year ago, on March 2021, and is expected to end by March 2026. This is the list of the partners. So we have partners from France, Denmark, UK, Italy, Portugal, Estonia, Romania, Ireland, Bulgaria, Belgium, and so going from the southwest, from the northeast of Europe. And I think one of the interests was truly to try to capture most of the figure of the condition, the disparities across the European country. I think that we have already been told about the figure. I think one of the points that was driving our wish to run this project is that EU updated the trend over time for the regional incidence for cervical cancer. And what you can see in most of these curves, so I'm not going to go into deep details, is that in fact we had a slight decrease in the incidence of cervical cancer screening, and now we have a plateau, and in some countries we even have observed an increase. The plateau means that the existing screening policies that have been put in place may have reached their optimal effect if we don't do something more to reach the women that we cannot manage to reach with the existing screening policy as they exist. We have been discussing the group of vulnerable women, and some of the group have already been listed, like women with low socioeconomic status, women living with HIV, women with other sexual transmitted infection, drug addicted, alcohol addicted. And what we can see here is that if we consider the general population as a reference group, we see that for some of the vulnerable women, the risk may be even 13 times higher. That's the case for drug addicted for many reasons. So that means that those women are really the women that for which we need to dedicate our effort if we want to improve the prevention against cervical cancer with the two pillars, which are HPV vaccination and adequate cervical cancer screening. Those are the results from an assessment conducted in France, and you have here the relative risk for cervical cancer screening, and you have the relative risk for different types of cancer according to the level of deprivation. And you can see that cervical cancer screening has almost a 65% increase risk for the most vulnerable women, and that is the cancer that is the most affected by social inequalities. And there is an imbalance between risk and prevention, and vulnerable women, I told you, have a 62% higher risk of cervical cancer screening, and yet their screening rate are lower. And you can see that the women who are not being screened are much frequent in the low risk women. So that means that they combine both an increased risk for example, for HPV infection, and they have also a decreased risk for cervical cancer screening. And one of the figures is that even in countries where cervical cancer screening policies have been well implemented, with a high success rate like 80% that it is in some European countries, the 20% of women who do not attend cervical screening, cancer screening on a regular basis, concentrate 50% of the cases and 70% of mortality. So that means that we really need to focus our efforts on the vulnerable women who do not attend cervical cancer screening. So the CBIG-SCREEN ambition is to unleash the potential of cervical cancer screening in Europe by empowering government and policymakers to reach out vulnerable women, making cervical cancer screening more equitable and improving health outcomes. So clearly, we want to make a cervical cancer screening more equitable, meaning that we need to dedicate maybe more effort to reach the small group of women who do not attend, but once again, who concentrate most of the burden of the disease. This project, I'm not going to go into too deep details, but the project has mainly 5 objectives, and the objectives are to define the implementation strategy. So we are not going to invent a new tool, a new device, a new viral method to screen women. What we want to do is to build a screen policy based on existing tools like HPV testing, like cell sampling whatsoever, to find a way to reach at vulnerable women. And the key issue we have, the key question we have is, how do we identify the vulnerable women across the different European countries? How do we manage to find a way to reach out to those women? The second objective is to map the existing screening policies, focusing on vulnerable women. And I can guarantee that in many European countries, in fact, there is no real and no specific focus on those vulnerable women. To make framework of co-constructed implementation models. So the idea is really that we want to define the best strategy, including the acceptability by the women we want to screen, to build tailored cervical cancer screening program that match vulnerable women's needs and preferences. And that means that we will use qualitative research approach. We use discrete choice experiments model just to truly understand what are the need and the expectation. And we will, of course, pilot test. And I see that Partha Basu from York is connected and will be speaking. And Partha Basu will be specifically in charge of building and piloting the tailored screening policy we have in mind. So 3 pillars support the project. The pillar 1 is the contextual assessment. So that means that we need to understand what are the key elements in each of the European country that may make given intervention able to reach or not to reach the vulnerable woman. We want to develop intervention packages, including context elements, once again, to propose screening policies more likely to reach the vulnerable women across the European 27 context, and of course, even above. And of course, if we finally define a screening policy that may be able to improve cervical cancer screening across the vulnerable women group that have already been defined, we need to assess these screening policies and to disseminate our results. So we don't want just to publish scientific papers, because scientific papers are not being read by the population that needs to be screened, and meaning that we need to dedicate effort to once again disseminate our results to the policymakers, disseminate our results to the health professional, but also to the women, to the representative of those different group of vulnerable women. That means that we have already developed, and thanks to Vanessa and the European Initiative for Women Health, who is in charge of developing this all dissemination event like Twitter, LinkedIn, and different type of intervention. Vanessa has been very active on LinkedIn by post, and we have this webinar. Thanks also to the European Council Leagues, Ginevra Papi and David Ritchie, who are really, really active in disseminating our event. And so the idea is we want to build capacity for risk-based cervical cancer screening strategy, and that is something that needs to be active, because we need, of course, to adapt and implement new screening policies with, for example, new approaches or new devices become available. We built community user boards, so that's the one way to build our intervention. So those were the facilitator meetings. So people from Bulgaria, Romania, Portugal, Spain, Italy, Denmark, who will be in charge of co-constructing and so bringing together the macro, meso, and micro level of people involved in cervical cancer screening. So policymakers, program managers, and field, so first line health workers and women themselves. Thank you very much, and you have here the website for CBIG-SCREEN project.
That's great, Mark. Thank you so much. Whistle-stop tour of the project. There's plenty more, but it was absolutely brilliant overview of what we're hoping to achieve now over the next 5 years. So thanks very much for that.
Thanks you.
Next, I have the pleasure to introduce Maeve Cusack. She's a board member of the European Institute of Women's Health, and she's here to speak to us about promoting cancer screening uptake. So over to you, Maeve.
Hello, thank you, Vanessa, for that. And thank you for inviting me here to speak. I'm very happy to. And it's really interesting listening to the other speakers, and particularly Mark. They're putting a flavour on the project and an understanding of where we're at. So I just have actually 2 slides here. We might, Tom, if you could go on to the second or the first slide. Really what I was going to talk about is from the European Institute of Women's Health perspective, an integrated approach to promoting cancer screening uptake. And so a lot of the work that we're involved with is around chronic diseases and particularly around gender issues, particularly for women, in terms of engaging with them and encouraging, different techniques of encouraging uptake for various programs. So I just look at this, we know for sure, and I'm sure most of the people at this meeting today will know that there is no quick fix approach to any of our interventions. It's a multi-pronged approach. And certainly from an evidence perspective, it's always around, there's no one size fits all approach to promoting cancer screening or promoting engagement in any behavioral change. It's always difficult. And, I think, as Mark said, I know in your talk there about looking at the evidence, and across Europe, there's, varying degrees, various elements. And I think that's something, obviously, in this project, you're going to be delving into in the next number of years. But if we look at this graph here, looking at public relations, engaging with populations, largely if a screening program, whether it's cervical screening or bowel screening, breast screening is in a certain region of a country, there'll be large scale advertising to say this screening is available, it's free for women or men. I think, but from the public relations, what we're talking here about is the hard to reach groups, and they're more vulnerable groups. So there are groups that we need to take a different approach with. It's not just a wide scale advertising that obviously won't engage with those women. And as Sirpa said earlier, these women vary from, they may be in prison, they're isolated in various ways. They're very much marginalized on the peripheries of society. So they're the women we need to engage with. And I think this project will be very interesting to see how it progresses across all the countries in Europe over the next number of years. Again, I suppose looking at website development and management, and Vanessa, I know, has done a lot of work on terms of communication and website development. This is something that's changing arena across Europe. It's very much now, it's all about website and what information is up there. And obviously we need this information to be as transparent as possible. So it's easy for women to obtain the knowledge and to get the knowledge. And also managing these websites, because a question could come up, but it needs to be answered, it needs to be monitored, and it needs to be managed. So I think all of this piece of information are obviously invaluable to how we encourage the women, that particularly the vulnerable women, to get involved and get engaged in screening programs. And just they'll see issues management. And this is something that we're very cognizant of in terms of, again, giving people enough information. The cancer arena out there, we all know, is a very cluttered arena, and the accuracy of information and how that information is drilled down or filtered down, I should say, to women is very important, particularly with the hard to reach women. Because if you take, for example, the recent pandemic, the flu or the vaccinations for COVID, there has been a lot of camps about, should we get vaccinated, should we not? So similarly, in any screening program, should I get involved? Should I go and have my screen or not? What's the evidence? What's the knowledge? And that knowledge base needs to be tapered for the hard to reach group, if it's a literacy issue or just a general knowledge understanding. I suppose that sort of marries in a little bit with print materials, because a lot of countries now don't use the print materials. They prefer to have a more website or electronic information process. But I think probably most of the people who are on this webinar now, if you're health promotion or public health doctors, will know that if a woman comes into you, to having a diagram even, or a printed material is often very useful method of teaching and engaging with the woman. So that's another, it's something I think just to be cognizant of and aware of. Again, the sustainability piece of public health messages, and as Mark was saying there about the focus here is on the vulnerable woman. And with any screening program, coming once for your cervical smear is not sufficient. It doesn't impact on the mortality or morbidity rates. It's the continually coming back for the regular smears as advised by the program. So the sustainability piece of public health messaging is going to be very important here. Again, literacy issues and language barriers, populations migrating across Europe. What country are they going to be in? Can they be called, in a call-recall register? All of those pieces of information will affect the uptake. And just going back there to previous speaker, the 20%, that's what we need to get at now. That's the 20% of the screening population for cervical cancer that need to be encouraged to take up their screening invitation. And just finally on this slide around public affairs, stakeholders, we in the Institute, we work very much across all the various groups in Europe, and stakeholder engagement is just so important in terms of cancer societies, certainly in Ireland and across Europe. All the regional and countrywide cancer society groups would have a big input in terms of women contacting them about questions on screening programs. So that stakeholder involvement is key, and I think we probably all know that. But that's just giving you a flavour really of the integrated approach to promoting cancer screening, largely in the eligible audience. The next slide, Tom, I just put up there is really talking about how this can be implemented, and I know that that's some part of this project, but just to give a flavour in terms of communications and promotion, it's not a one size fits all. There are several aspects to it, and that could take a whole day to discuss. But I suppose briefly here, just looking at the research and the evidence, in interventions that influence behavioural change there's a depth of information out there. And we had a recent 2017 meeting when we were developing our European Institute of Women's Health manifesto going forward into 2025 and looking at our action plan. And we brought many of our members of the Institute together and looking at all of the evidence and the research. And there is a huge body of research out there, but it has to be taken into account when we're looking at that communication, health promotion, public health strategy, and the whole framework. And it is a combined approach in terms of looking at the communication, and it will be different, as we know. We were saying there earlier that maybe 60% of the population will take up the screening program, but it's the other percentage of hard to reach and more vulnerable groups that will require more specific and tailored screening and communication strategies. And just finally here, just influencing behaviour. You see a nice picture there, if you can see it on the screen, of a lovely beach and strand in County Kerry in Ireland. And whilst it's a lovely location, nice place to be, but a lot of people live in very isolated areas, not just in Ireland, across Europe, and it's not that easy to access the services. So we need to make it easy. We need to make this choice for very vulnerable women across the world, a very easy choice to participate in screening programs. So that's really all I wanted to say. I mean, there is a lot more I could delve into, as I say, but I think just to give that flavour that we are looking at the more vulnerable groups, and I'm happy at the end to answer any questions that you have on that. So thank you for that.
Great, thanks so much, Maeve. Very interesting to hear, great insight just how these groups can be reached. Just conscious a little bit of time, so moving swiftly to Dr. Partha Basu. He is from the WHO International Agency for Research on Cancer, IARC, and a CBIG-SCREEN partner. So over to you now, Partha, to speak about the project. Thank you.
Thanks so much, Vanessa. Let me share my screen. Good afternoon, everyone. At the International Agency for Research on Cancer,
sorry, Partha, we can't see your screen, Partha. Apologies.
Oh, okay, I'm sorry. Is it visible now?
It's coming up. Just give us 1 second, sorry.
Is it okay?
Yeah, good now. Thank you.
Thank you so much. Good afternoon, everyone. Wonderful collaboration, and especially because the middle term strategy of the international agency has identified the implementation research as one of its key research focus areas. And as you know, CBIG-SCREEN is a classic example of implementation research. And why is implementation research particularly important in today's cancer prevention, cancer early detection research? We have learned our lessons from experience. About 10 years back, we were very excited because we thought that we had found a wonderful intervention that can really ensure access to treatment of cervical cancer in low and middle income countries. This particular technology known as cryotherapy was shown to be very effective, very safe in randomized control trials. And it was, the recommendation came in the WHO manual in 2011 after the randomized control trial evidences were synthesized. But what we missed was that we didn't look into the implementation challenges of this particular technology. And there were a couple of very serious implementation challenges. One was, as you can see on the right-hand side, this particular technology requires the refrigerant gas, which comes in a tank. And on the right-hand side, you can see from the size of the tank, it is very difficult to get this tank moved from, from one center to another, making sure that the supply is regularly maintained. And within this tank, there is the refrigerant gas, which is expensive. And it's very difficult to get in many of the low and middle income countries. So starting from Bangladesh to Zambia, everywhere this implementation challenge was observed. And what happened ultimately was that this technology was almost dumped. So we really have to be very pragmatic when we think of bringing in new interventions. We have to do intervention research, which essentially looks into, into the effectiveness, looks into the safety of the intervention and other intervention outcomes, usually through randomized control trials. But then the next step, and the very key step, is to go for implementation research. That essentially looks into how to adopt, how to integrate these evidence-based practices into routine public health setting. And that is exactly what CBIG-SCREEN project is doing. So in terms of cervical cancer screening and ensuring the high uptake or high access of screening to vulnerable women, we know what will work because, number one, we have the evidence coming from several randomized controlled trials that HPV detection-based screening and probably self-sampling is the best way to go. We are also synthesizing evidence on what other different strategies work to improve access. But then how do we implement these specific strategies in real health setting in different countries? Because every country, even within country, the health settings are very, very different. So we need to look at this implementation outcomes, which are essentially the feasibility of that particular strategy to be implemented, the fidelity of that strategy, acceptability, and so on and so forth. And ultimately, we also look at the service outcomes. What are the service outcomes? Service outcomes definitely looks at effectiveness, safety, but then also efficiency in terms of the time spent, in terms of the resources spent in a real healthcare setting. And these are the service outcomes we need to look for. And if these outcomes are all right, we are expected to get the appropriate health outcomes. So that is how an implementation research model works. And it has a framework. Generally, this framework we have applied for the CBIG-SCREEN study, where we are essentially looking at how to improve access to HPV detection-based screening for those women who are identified as vulnerable in different settings. So what are the things we need to look at? We need to look at the characteristics of the intervention. Say, for example, one intervention can be, self-sampling. If that is an intervention, then what is its relative advantage on the standard of care? What is this advantage of the current practice, which may be cytology-based screening? What is its complexity? What is its cost? So these are the characteristics of the intervention. We need to take a deep dive into the inner setting of the health system that is working. That means within the primary health care, say for example, what are the specific resource needs? Is the primary care in Estonia ready to implement HPV detection-based screening? And if so, what are the structural characteristics that need to be altered, improved? So these are the inner settings. And as you know, any intervention can be impacted by outer settings, which are essentially national policies, health priorities. And then, with the COVID pandemic, several of these priorities have changed. So we need to look at the outer setting. We certainly, at the center of the whole issue are the women whom we are targeting as, the target individuals. We need to understand their knowledge, their beliefs, their demography, their individual risk factors. And finally, there are several implementation process aspects that we need to look at. How do we plan for a new strategy? How do we ensure that there is adequate workforce to implement those strategies? How do we implement evaluation and monitoring, what we also call quality assurance? So using these specific framework, we designed the CBIG-SCREEN study, which is essentially, it has 4 phases. In the phase 1, as Professor Mark Badu already explained, that most important thing in any implementation research is to work very closely with the stakeholders. Without them, implementation research cannot work. So having them on board and looking at the context, what are the barriers, what are the challenges, what may be the facilitators. So those are the things we are going to look at in the phase 1. In phase 2, again, in close collaboration with the stakeholders, we are going to identify a certain strategies which has to be multi-level. It cannot be a single strategy. And again, as we already heard, that one size doesn't fit all. So we need to have multiple strategies, looking at the context and making sure that those strategies are appropriate to the context. Now, once we have that kind of strategies lined up, we need to move towards field intervention trial. And that is what, as Professor Mark Badu said, we are leading at IR within the collaboration. So we are going to look into through a field intervention trial, whether those strategies are really working or not. If they are working or they are not working, why is it so? That is also important part of intervention research. And finally, once we know that certain strategies work, the research doesn't end. We need to understand, is that sustainable? Is that acceptable to the policymakers? Do the policymakers have adequate opportunities to know about these new strategies? So that is the phase 4 of the implementation research. So just to give the summary of what we are going to do at IR, number one thing is to understand the context. We are going to see what is the current standard of care in terms of HPV detection-based screening in 3 of the intervention countries. As you know, we are targeting Estonia, Portugal, and Romania. So, and then we are also going to do the capacity assessment of the health system to implement new strategies, whether they are already overburdened, whether they are really prepared to bring in new strategies. If they have to be prepared, what additional things need to be done? And then the third thing we are going to, as I said, we have to implement the intervention trials, and then try to see whether those strategies that have been identified by our stakeholders, whether they are working or not. And for that, we are going to run pilot implementation projects. And then from there, we will understand whether these are effective or not. And then also we'll understand the readiness of the system. We'll understand capacity of the system to sustain those, and the capacity of the system to scale up those interventions. And one final deliverable of this project is that we will create opportunities for any country within Europe and outside Europe to use our protocol, to use our tools to run similar implementation research programs. As you know, in the context of cervical cancer elimination, each and every country has to try to see to it that their women have access to the best of screening, which at the present standard of care is HPV detection-based screening. And this CBIG-SCREEN project is going to ensure that. Thank you so much.
That's great, Partha. Thank you so much for that. Really great to get kind of a deep dive into the research behind it, or the plan behind it. So I really appreciate that. Thanks a million. So we have a few minutes extra for some Q&A. So I'll get to one of our first questions we got in is from Keenan Russell. I hope I get your name right, Keenan or Keenan. He's asking, one hard to reach group is trans men and non-binary people who have cervixes. Is there any intention to incorporate this group into the work? Maybe Mark, you might answer that.
Well, yes, so that is a very relevant question. The point is that, you know, one of the key issues when we want to reach vulnerable groups is to be able to reach out to them. So that means that because when you want to develop screening and screening policy at a national level, even if you want to target these some very specific subgroup, the key issue is how are you going to reach, identify these people. And I think clearly one way will be to, assuming that we were to find a way to improve cervical cancer screening among vulnerable group, to disseminate the information. But clearly, transgender, non-binary people are one of the group that needs to be targeted, and we absolutely have this group well in mind. And you know that when we submitted the dossier, there were a very specific chapter on sex and gender issues. And even if we have been saying that cervical cancer screening is a cancer which affects women only, but the point is that that is not that simple. And this is really something that we have well in mind.
That's great. Thank you, Mark. Absolutely. It's important to, to keep in mind to include all groups. We have a second question as well for Sirpa. Sirpa, as a member of MEPs Against Cancer and in relation to your broader legislative work in the EU Parliament, how would you advise the CBIG-SCREEN project and other projects to engage effectively with MEPs to secure their support for the results of their projects and also feed into, for example, the updating of the Council recommendations on cancer screening and to ensure a specific mention of vulnerable groups in the revised recommendation? So a bit of a mouthful, but that was the question.
It's quite a mouthful, as you said, but really, as you all can see and hear, this is on the crux of the whole Beating the Cancer plan. It goes in line with that. Okay, you prevent, you screen, you diagnose, and you treat. And especially in cervical cancers, the screening, as we hear, has been this very vulnerable part of the project, like in some other cancers. But here, for various reasons, it is very obvious and imminent source thing to be taken care of. And that's why it is good that this project exists. And while you have these good results out of it, so the best practices, I hope you could share it with the MEP Against Cancer group. You could deliver it to all member states with this kind of an easily accessible format, almost a infograph or points from 1 to 10. Okay, start with this. And this is the procedure how you make the services mobile, for example, the remote areas. This is how you break the religious or cultural barriers that might still exist somewhere. This is how you add the language pieces and have a better access to immigrants and so on. So quite sort of this kind of a concrete plan that I quite clear see and hear you are preparing. And by that way, we could sort of support it as a MAC group. We could support it as parliamentarians. And if we send it to all MEPs, we could ask them to approach their own ministries of health and development, so that both, of course, that would be taken into account as part of the national cancer plan. This in cervical cancer, for example, in Finland, we have our own patient organization working with cervical cancer, to take them into a board, because we need to pressurize the governments to set a higher priority for this. Plus then, of course, our development ministers in the council, because as I understand, we need to be doing the work outside the EU also, because people in other parts of the world are human beings and need the access for screening and care also. And this is a very good advice what I hear you saying and preparing already on this side. So this would be my sort of first reaction about the activities, just to make it seen, make it heard, make MEPs to contact their own ministries, send it to ministries, and ask the MAC and national cervical cancer groups where they exist, or cancer groups if they do not, to pressurize the politics.
Great, thanks so much, Sirpa. That's great. Some good advice there of how to get to the bones of it. I'm just very conscious of time, so I think we'll have to leave it there in terms of questions. I just want to wrap up everything to say thank you so much to Sirpa, our co-host, Sirpa Pietikainen, MEP. The EIWH, we really appreciate your expertise, and you're really a great support for women's health, over the life course of the woman's life. So we really appreciate all your help, Sirpa. Thank you so much and your support. Also really want to thank Mark Bardot for his dedication in putting the CBIG-SCREEN project and consortium together. Want to sincerely thank our other speakers, Dr. Partha Basu and Maeve Cusack, for participating today. And last but very much not least, I want to thank everybody who participated in the webinar today, who attended. So thanks so much. I hope you all enjoyed it. The EIWH strongly supports the European Commission's Beating Cancer Plan and the focus on prevention and screening. And we look forward to supporting the implementation of the plan at a national level. As a member of the Beating Cancer Stakeholder Group on DG Sante's Health Policy Forum, we have particular interest in the newly established Cancer Inequalities Registry. Prevention of cancer in women is a priority for the EIWH, and we're delighted to be part of the CBIG-SCREEN project. And we look forward to focusing on vulnerable women and supporting their uptake on cervical cancer screening. Finally, the CBIG-SCREEN Consortium are looking forward to working with all stakeholders who want to prevent cervical cancer, and of course to contribute to the Cancer Inequalities Registry. We look forward to sharing the progress, findings and outcomes of the CBIG-SCREEN project with you all over the next 5 years, and you will be hearing from us soon again, hopefully with some more outcomes and findings. Thank you so much for your time today, for attending our webinar, and we hope to see you soon. Thank you.
Thank you very much.
Thank you.
Thank you.